Cool. Can you make me host, Tim?
Yes, I certainly will.
Because I want to try.
Done.
Cool. Now, I just need to figure out.
So, guys, welcome to Surrey Physio CPD tonight. For those that can't make it, we'll record it so you can watch it in your own time. Thanks to everyone that has made it. Chris is, what's the topic tonight, Chris?
Investigations.
Investigations.
Does anyone know how to do breakout rooms? I just wanted to get that set up first, but I can't remember where to do it.
I'm not sure about
Roy Bateman's your man.
Okay. Or maybe we'll just do it in one group. All right. So. Okay, so we're going to talk a bit about investigations and have a bit of a discussion around it. Can you guys see my slides?
Yeah.
Yeah. Okay. So just a few things that we can go through is just what role do we play as FCPs? Why do we do investigations? What investigations can we do? What to do if a patient, or in some cases a GP, is pushing to have a scan, like we were joking about just now. I've got back pain, can I have a scan, please? How to send for these investigations, because the different areas that we work in all have different procedures. How do we interpret these investigations, and what do we do with the results? So firstly, what are we doing as FCPs, as physios, as osteopaths, and so on? And I saw this somewhere, I think it was during, what was that course that just happened now? I forget its name.
The big day.
Yeah, the big day thing. Can't remember what it's called. And someone said, we're there to make sense of their suffering. So I think if patients understand what is happening to them, I think we go a long way to helping them improve and help them sort out their pain. And then once we've done that, we can then provide a plan or a program to facilitate them to return to their recreation or their occupation. Just keeping that in the background the whole time. What are we doing, and where are we trying to help our patients? So why do we do investigations? Can anyone, do you guys have any opinions about, well, okay, that just gave you my answers, but does anyone want to jump in and give us a few reasons why we do investigations?
Confirm your clinical suspicion.
So rule something in?
So yeah, rule in and rule out, I suppose, in the same token, essentially.
Yeah. Anything else?
Clearing non-urgent red flags. For example, x-raying a frozen shoulder. I know that's a bit of a debatable topic.
Yeah. So kind of, in that case, I would say ruling something out. So you're suspecting something by ruling out, bone tumors or fractures or arthritis. You can be more confident of that diagnosis by ruling something out.
I suppose you can be preparing the patient for secondary care, i.e. if they're going for an ortho opinion for knee, hip, shoulder, they need prior scans. Probably easier for us to get some imaging and scanning done in primary care. And I feel like it's prerequisite for a lot of some of the ortho consults.
Yeah. So
to provide appropriate management, probably.
Yeah. So what you're saying there, Alan, and I don't want to put words in your mouth, but is to sort of guide treatment in a way, and also what Dan was, what Dan was alluding to there as well is, I think if we're going to be sending patients to orthopedic surgeon colleagues and so on, is it's to guide treatment. And what I often tell patients is saying that if you absolutely, there's no ways that you're going to have a knee replacement, then there's no benefit in going and doing a scan necessarily if you just absolutely will not have surgery no matter the case. Then if we're doing the scans and investigations, it's not helping us guide the treatment, because the treatment's not going to go anywhere beyond where we are now. I don't know if anyone disagrees with me there or has any opinions on that.
No, I agree. If we're going down the conservative path, a lot of the pathologies we can diagnose without imaging, but if we need to escalate it or again refer on to secondary care, I think then it's appropriate. Just back on the actual frozen shoulder one, it's interesting. I listened to Andrew Cuff. It was called Therapy Live, Chris, the 2-day or 1-day event. And he was talking about screening red flags, and in particular, does he routine image the frozen shoulder? And interestingly said, he doesn't, yet if he refers to secondary care, he always does. So, which is interesting, because obviously as FCPs, if we suspect a frozen shoulder, 9 times out of 10, we're going to refer for ongoing physiotherapy. So in that instance, he would image, but if he's only seeing them, I suppose, and following them up, he doesn't. Which I was like, okay, so that's kind of well, I suppose it gives a bit of clarity, but
yeah, profession's really torn, because 4, 5, 6 years ago there was this big push to X-ray a large majority of frozen shoulders, and I think actually recently they did a study where they X-rayed about 500 frozen shoulders, and they found sort of 2 secondary tumors, 2 fractures.
I think that's the study he presented. Yeah, it was minuscule. Like there was nothing, like 0.5%, if that came up.
Yeah, it's really
positive.
really small, and
so it does back up. You don't really need to really. If
I
you can,
agree.
Yeah.
I don't think anyone would hold it against you for missing a secondary in a shoulder or a fracture in a shoulder if there'd been no trauma or no red flags to not X-ray. I mean, I just think X-raying shoulders is for a frozen shoulder is just not necessary. But the profession are torn on it.
I think a lot of it you need to do a bit of clinical correlation as well. How did the frozen shoulder start? Age group. I think we can quickly pick up if there's a frozen shoulder that doesn't just seem quite right to us sometimes. If there has been secondary trauma, probably worth checking. So I think it's using that clinical correlation, but I don't routinely X-ray them if it's pretty obvious that it is a frozen shoulder.
Yeah,
I think it also matters how long they've probably had the frozen shoulder as well, isn't it? I mean, if you're talking 2 years of frozen shoulder, that's not clinically sound, is it? I mean, that would be a different sort of aspect to then scan it. But I don't typically do scans for frozen shoulder. I don't X-ray frozen shoulders, not at all.
I think if you look at that study they were talking about, is they had quite strict criteria in terms of what they defined as being a frozen shoulder, in terms of the age group and the symptoms in terms of external rotation loss and things like that. And if you have those signs, you can be pretty confident it is frozen shoulder. I think in one sense, if the system that you work in requires them to have an X-ray prior to having an injection, then you kind of have to, like, clinically. You might think it's not necessary, but unless the system changes, and there's ways of doing that, but unless the system changes, we need to do that, or else the referral is just going to bounce back and we're just wasting our time. So
but some hospital trusts still do have in place that you need to X-ray frozen shoulders as a routine. So
I wouldn't be surprised if St George is knocking back our referrals because we haven't done it either.
I mean, they would use any opportunity, wouldn't they?
Yeah, cool. So then, what joints can we? People's faces in my way. What interventions can we do, and what joints conditions can we do them for? So I think it's already popped up. I haven't obviously got my animations working too well. But yeah, so we can do x-rays, we can refer for, well, we can't do x-rays, we can refer for x-rays, we can refer for ultrasound scans, MRIs, CTs. I don't think we can refer for CTs. I think that's got to go through MECAS, and blood tests. Will, I think you're the clinical lead in Wandsworth. Do you want to just explain briefly for everyone in the group and maybe watching this later on, what joints can we refer for MRIs, maybe ultrasounds, and I think x-rays is pretty explanatory there.
Yeah, great. So as you said, I think Wandsworth and Lambeth, we're pretty lucky compared to Croydon because we can refer for most scans. X-rays across the board we can refer for. I don't think there's anything that we can't do. MRIs is where it gets a little bit tricky. It's probably easy to say what we can't do. So in Wandsworth, you can't refer for hip MRIs, ankle/foot, or hand or wrist. Everything else you can, as far as I'm aware. If you want to refer for any of the others, it needs to go through MECAS, which obviously kind of goes against what they say, because they say, well, you must scan before you send to us, but they're more than willing to accept those. Ultrasounds, as far as I'm aware, we can refer for pretty much everything. The nice thing about ultrasound scanning to remember is if we send it to the hospital, especially to St George's, we can ask for a guided injection at the same time as well. So if we have got someone, let's say, with a subacromial pain syndrome that hasn't been getting better and we want to confirm pathology, you can almost double up on confirming pathology and treatment at the same time. CT scan, I've never done one. I've never seen anyone do one. I asked for one done referred by a GP before because I was concerned about the brain. I think that would be the pathway, either sending it through MECAS or asking the GP to organise. And then blood tests. A lot of this will depend on the access you've been given on your smart card, or if you have a smart card. But most generally, I think most people will be having to ask the GP to organise the blood tests. And standardised blood tests that we'd probably look for would be full blood counts, ESR, and rheumatoid factor if we're considering inflammatory markers.
Yeah. Sue, are you still on yet?
Yes, I'm here.
You're in Northeast London, yeah?
Yes, I'm in Northeast London.
Is that much the same there as well in terms of scans?
So in terms of scans, it's a little different. So you have a little more autonomy. You're allowed to refer for your MRI, X-ray, and ultrasound without having to kind of ask your GPs for permission. But at the same point of time, the GPs normally do it before it gets sent to you because of the wait times. So if the patient is normally coming to you, they will normally have their scans done before it's coming into you.
Okay.
Yeah.
Who's under Croydon? Alan, are you under Croydon?
Yeah, it's me actually.
Okay. So do you want to explain a bit about how it works there?
So I think pretty much similar to Lambeth and Wandsworth. Normally MRIs, it's more tricky around MRIs. X-rays we can refer for any X-ray we want. Ultrasound scans we can refer for any ultrasound as well. MRIs, it's a bit tricky because MCATs wants MRIs to be referred through them, and some questions pop up on Sun's IceQuest saying whether they've had a scan before and the radiologists are requesting for. So MRIs are not all of them are straightforward. I've never seen a CT done. I've never particularly done a CT. With blood test, again, there's an open autonomy for us there. We can do anything from basically inflammatory arthritis to even uric acid as well, urea levels for gout and stuff like that. So yeah, that's Croydon.
Okay. And with X-rays in Northeast London and in Croydon, are there walk-in centres available, or do you have to book appointments, or how does it work then?
So in Northeast London, I think there's more of walk-in centers that you can have your X-ray kind of X-ray referral given to the patient, and they can walk in. Alternately, they have the option of booking an appointment as well if they don't want to if they want an appointment slot. So it's a little more versatile, sort of just say that, you know, depending on the patient, what the patient needs to have done. But a lot of GP surgeries in the area now have their own kind of, for blood tests, they have their own phlebotomist. So you just need to print out the form, give it to the phlebotomist, and they call them in.
Yeah. So in Croydon, it's X-rays are walk-in, blood tests are walk-in. Going to Purley instead of Croydon. To Purley, they would, for X-rays, they would have to book an appointment. So yeah.
And I think that's all the boroughs that we've gone through there, or the main areas. So Wandsworth, Croydon, Northeast London, I think those are all of them. If I'm wrong, speak now. Or
Yeah, we have Sutton as well. So
yep.
we can refer for X-rays and ultrasounds. I'm not quite sure about CTs. Actually, I never needed one. We can't refer for MRI, so that's a bit annoying. We have to refer them to orthopedics or the musculoskeletal service at St. Heliers, but we don't have, well, if we refer them to orthopedics, we can suggest an MRI, but that's not guaranteed that the patient gets an MRI. If we refer them to the MSK service, it's them who decide whether they will get an MRI. So we can't even send them a written referral. So that's a self-referral service, a bit like in Croydon. And blood tests, and there we are free. So we have a system which is called DART, and we can order basically everything that the GP can order.
Okay. Sorry, I thought Sutton fall under the sort of Greater Wandsworth sort of region, but okay, so that's separate.
That's
as
separate,
well.
yeah.
Okay, good. Thanks, Isabel. Anyone else? Anyone else I left off?
Well, we have Aldershot, Farnborough area, pretty much the same. So X-rays we can refer, ultrasound we can refer, but they are a bit obnoxious time to time. MRIs we can't refer, nor the GPs at the moment. We have to refer to the orthopedics for triage, which takes absolutely ages. My last patient took 6 months to have a telephone consultation with the orthopedics. CTs, as far as I know, we can't refer. Blood tests we can refer, but patients has to book appointments, and sometimes it takes a month for them to be able to book an appointment.
Is that blood tests or X-ray?
Yeah, yes. In Aldershot, especially in border practice, sometimes they wait weeks and weeks for an appointment to come up.
Gosh. Okay. Cool. All right. So we're going through this. But just because, okay, some of us can and some of us can't in these situations, I think we sometimes have to ask ourselves the questions of should we, and that's why in the wise words of Uncle Sam, with great power comes great responsibility. And for me personally, in terms of blood tests, I feel more comfortable sticking to within musculoskeletal realm, and in focusing on the arthropathies, you know, the ESR, the CRP, rheumatoid factor, anti-CCP realm, and maybe a joint infection if we're suspecting that. But in terms of some of the other stuff, for me personally, I don't feel I have enough understanding of all the different things, how they all integrate and work, and I don't want to miss something, so I would rather refer that on to GP colleagues and have a chat with them about it. Yeah, that's just my view. Sorry, I'm seeing the chat going. Is there anything important in there?
I think Stav was asking in Croydon, how does ultrasound scanning work?
Okay. Go ahead.
I mean, we actually need to refer for it, and it's a 4-week wait.
Okay.
After they've completed 4 weeks, if they don't get an appointment, then they would have to call radiology and get an appointment fixed.
Cool. Okay. So this was a study that was going around on social media recently about the unintended consequences, quantifying the benefits and iatrogenic harms and downstream cascade costs of musculoskeletal MRI in UK primary care. And what they found, if you do want the study, I can send it to you, but basically the conclusion was 2/3 of image patients, for them, no treatment actually changed. So 2/3 of patients have scans done and nothing actually changes in terms of their treatment pathways and so on, which probably means that they probably stick in to conservative treatment and so on, and nothing really changes. And that a lot of times having scans that is actually generating a nocebo effect in terms of patients' beliefs and expectations, and then the appropriate care for patients who do need things is then delayed, and there's certain consequences of that. So it's an interesting thing in terms of, it was a study done on GPs. It'll be interesting to see what the changes if FCPs are referring for scans, and then how that changes. But it's just something to be aware of, I think, is the downstream effects of that. And if you don't know what nocebo means, it's basically a harmless thing that causes you harm because you believe it to be painful, which is kind of like saying when the doctor says this is going to sting a bit, and then they do something and you then feel that sting. They've planted that in your mind, and then you're expecting that thing to then happen, which is an interesting thing to just think about. And then how do we interpret these investigations? So all of us are pulling up patients' histories and looking at their scans and the details of everything that's gone on. This was another study. I think, Dan, you shared this on the group, I think, and a discussion on Twitter about the prevalence of pathology, you could call it, or findings on X-rays and scans in asymptomatic populations. I remember when these studies first started coming out in terms of knees, and then it was back, and then more and more of these studies have been done. And just to point out that in the neck, things like bulging discs, degeneration, I'm sure most of us are familiar with these types of studies in terms of the back disc degeneration, 70% of disc bulges in certain age groups, labral tears in hips, 70% of asymptomatic adults in that one study, meniscal tears in the ankle, ligament tears. I was quite surprised with that one. Achilles tendon problems. So basically, the whole way through the body, asymptomatic people having scans are showing what looks like, findings on investigations. So my few questions are, if we're finding similar findings in symptomatic and asymptomatic people, does this mean that these structures don't cause pain?
So I think, Chris, from our point of view here, this is where it's really important that we use our clinical reasoning and clinical correlation, because I'm sure we've all seen scans come back which say for specialist opinion, because there may be, I don't know, stenosis, something like that. But actually, when we've seen the patient, we need to make sure that we are correlating those symptoms, because, as you say, there's so many things that may come up in an MRI scan. But if the patient doesn't suffer from those symptoms, that what we've always got to think, why are we referring them on to orthopedics? Even though there's been that recommendation from the radiologist, they've not assessed the patient. All they've done is scan them, maybe with the slight difference being an ultrasound scan. So it's using that clinical correlation and clinical reasoning as to matching the scan up with the patient's symptoms, and then coming up with what we want done for that patient is really key.
Yeah. I think a lot of it is how we explain the scan findings to patients, and I've seen, and I got into a bit of a discussion with someone on Twitter about this, is some people I've seen use these findings to tell patients, no, asymptomatic and symptomatic people have the same findings, so this thing is not causing your pain. And I think we really do need to have good clinical understanding of what we telling our patients, because my understanding so far is more on how these things guide our treatment. I'll share my slide again. Sorry.
On that note, I think we need to be careful as well that if we do send off for imaging and the radiologist gives their recommendation of what's driving their pain, I feel like it's nearly impossible for them to say that if they actually haven't assessed the patient. So, for example, if we get a patient who's already had their imaging, that might be a telephone consultation, you haven't assessed them face to face, I don't see how you can refer them on to any secondary care without assessing them face to face, like Will said, to clinically correlate those symptoms to the imaging. And I know a lot of GPs do it, send off for x-ray, recommendation, blah, blah, blah. All right, we'll send that off. But like Will said, that, and with the findings from these investigations, asymptomatic people have these findings. So the biggest thing we need to do is that clinical correlation. I think you made an example, Chris, before of someone's got like a L2 dermatonal pattern of pain, but they've got foot drop. That doesn't really correlate with the findings with how they're presenting. So I think that's important that we need to again do that.
There's always this pressure, isn't there, from patients to get scans done. But in fact, in Croydon, it's actually a bit easier because we can literally just turn around and say, we don't have access. And you guys actually have more responsibility, like you said, with the Spider-Man quote. You guys in Wandsworth actually have a lot more responsibility because you do have access. So it's a lot harder position to be in. It's actually easier for us in Croydon just to go, it's not our decision. We can't say yes to you. So you need to have that conversation with another provider. But meeting patient expectation is interesting because as soon as you do scan them and then they know there's nothing majorly wrong, they kind of just disappear as well. So there's that. It's really hard to match the patient expectation.
Yeah, because where I've come to my conclusion with this is you might get a specific diagnosis, say with a meniscal tear. So it can say, it's got this type of tear and so on, but that doesn't mean if there's a specific diagnosis or structure that's involved, it doesn't mean it needs a specific treatment for that specific diagnosis. In that it might still be the meniscus or the joint degeneration might be part of what's driving their pain, but it doesn't need a specific intervention in terms of surgery or injection or something like that. In that we can still manage those things with a more broad-based treatment approach by load management and walking aids and weight loss and all those other things, that it doesn't need a specific treatment. But that doesn't mean that everyone with a meniscus tear mustn't have surgery, because that's kind of one one of the battles that I've found is I had a lady with like grade 4 cartilage damage. I mean, it literally was like, you know, people joke about bone on bone, but the report was saying that there's, you know, the cartilage is gone, and she was, the physio triaging it declined the onward referral and kept her in conservative management. And I think there is a point where patients do need to go to that next level. There are patients that do need surgeries and things like that. It does reach a point, but it's all about the clinical reasoning that not every patient needs surgery, but there are still a small percentage of patients who do, but we need to be justifying that and explaining that clearly, and then explaining to patients. And what I think is really important is we don't have to change the structure to improve their pain or their function. And I think that's what those findings are showing us, is asymptomatic people can still have a labral tear and be asymptomatic. So there's other things that we need to be addressing to improve their function and their pain. And that's where physio is best placed to kind of sort that out. So the clinical reasoning is so important. Anyone else want to jump in there? Alan, you?
Yeah. So I normally quite often see GPs refer shoulders for X-rays, you know, and with patients sort of 60 and above, I mean, probably 55 and above, you're going to see some arthritic changes. And the X-ray interpretation comes as wear and tear. You know, when you bring these patients in clinically, you kind of see it's more sort of a shoulder impingement, or you're concerned it's a rotator cuff tear. And the wear and tear, does it really play a role? So I think clinical sort of correlation with the whether the investigation is necessary is also important.
Yep.
I think you hit the nail on the head, Chris, in terms of the conversation that we have with the patient to either confirm or not deny, but say otherwise where their pain is coming from is probably the most difficult job. In terms of, you tell a patient, yes, you have an arthritic knee, but yes, we acknowledge there is arthritis on the knee, but physiotherapy, conservative management will help you. And when the patient asks, but how? I think that's the hardest thing that we need to obviously convince patients and manage their expectations and get them to buy into it and believe, okay, I can get my arthritic knee better without someone giving me a total knee replacement.
In terms of what you were talking about earlier as well, Tim, and with that, Dan, as well, is how we set up them going for an investigation and say, I'm worried about, you know, if it's a back pain patient and say, you know, they've got neurological symptoms, there's a whole bunch of stuff happening, we're not too sure what's going on there. Like preloading it and saying, we're looking to see if there's anything, or yeah, let me try and word as well. We can do an MRI. We're looking for some specific things. We probably will find, you know, facet the degeneration. We might find some stuff that's not relevant. So be aware of that when the scan comes back, we might find things which are not indicative of your pain and have been there prior to your pain starting, and almost preempting that. So when the scan comes back and they see it, or the GP picks it up first and then talks about it and explains, oh, you've got, you know, this facet joint degeneration, there's no disc bulges, and there's this and this. Oh, well, there is that, and that must be causing my pain. But we've preloaded that already and said, look, we're probably going to find these things, so don't be shocked when you see that come up. Sue.
Yeah, I've got another thing to add in terms of managing patient expectations, because there are a lot of patients that come in and say, okay, I really need you to do the scan because I want to see what's happening. I think also having a conversation with them and saying, you might want the scan, but my management of you is not going to change because this is what I think it is also a kind of good conversation to have. So when that scan does come back and you're saying, see, this is what I expected, this is based on my clinical judgment and my clinical reasoning, which is why the treatment is not going to change, and it's going to go ahead from there. So that's a good conversation to have as well.
Definitely. And what I've often said with patients is, I think it comes from your subjective and going, there's no neurologic, a patient comes in with just lower back pain and they want to scan. You say, you didn't report any numbness, you didn't report any pins and needles, you didn't report any radiating pain, there's no cauda equina symptoms, there's no bladder bowel dysfunction, there's nothing like that. So right now, we don't have any signs of serious pathology. You now know the signs to look out for, and if any of those things do come up, we can still look at, referring you on and investigating things further. But right now, your pain is located just in the lower back. You've been working longer hours or sitting in a chair, whatever the history may be. Let's start treating that first. And if any of these things do crop up, so you still leave that door open and they don't feel completely pushed aside and say, I'm never getting a scan, no matter what happens, it's just not going to happen. But saying these are the indications to look out for, and contact us back again if you do notice any of these things. Although, having said that, I have seen some patients lately who seem to know all the things to say in terms of getting a scan. They'll say, I've got this and this and this and this, and you go, this is a very rehearsed answer here. So obviously you got to use a bit of intuition there. But I think not shutting the door on them and explaining this is why you don't need it right now, I think can be helpful in those situations as well.
I think you've made a good point in terms of, I think taking a really good subjective history and even doing an objective examination allows us to gather all the evidence to show the patient essentially that, okay, we're not worried about that sinister pathology. You're not broken. You do your reflexes, muscle test, blah, blah, blah. You got full power, full strength, full sensation, blah, blah, blah. We're not worried about this. And if you do your examination properly, you show the patient that, you're not broken. You don't need further imaging or blah, blah, blah.
And I think that goes back to my first slide in terms of saying, if we can make sense of a patient's suffering, because they're going, but my back is so sore, I can't walk my kids, I can't do this, it's so sore, it's it takes me half an hour to get dressed in the morning, blah, blah. If you can make sense of what's going on and they can understand that and you can explain it, then they've bought in to you. And then when they say, and it's usually one of those comments, yeah, but what about a scan? You can say, well, we've gone through everything, we've checked everything, and you've gone through a thorough process. You can say, look, based on our findings now, you're fine. So, yeah, that's my view there. Anyone want to add anything else? Good. So it's going to be more of a practical question in terms of referring, but maybe that's something that can be done in some of the groups, Monday meetings and so on, and just in terms of practically. And I don't know if there's any of the new guys who need any help with that in terms of practically, how do we send for scans? Any of our newcomers have any trouble with that?
It is through DXS, right?
Through what?
When in the practices where I'm working, usually we have to send it through DXS.
You need
Some
to,
cases,
yeah, you need to send DXS to MSK Cats.
yeah. But in some cases now, because I'm still new, they didn't give me access for the DXS. So far, I needed just one scan. So I've been with the doctor I spoke. So we had a sort of conversation about the patient's history. We found out that the scan would be ideal to identify what he has exactly, because it wasn't a face-to-face appointment. And we send them for a scan, but they refer them, not me.
Yeah, exactly, Hector. So just mention to practice managers, you just need to get connected to DXS. And if they don't,
I mentioned they're just waiting for the guy who's making it. That's what they told me from most of the practices, and they already noted down, so most likely they will fix it.
Fine.
Yeah, so that was, if I knew how to do my breakout things, I would have had a little chat around there, but that's okay.
Chris, can I talk about x-rays?
Go for it.
So one thing we really want to be careful of is patients walking in with fractures and us not realizing. So fractures, it's just worth mentioning when fractures are a red flag and not a red flag. And I think we need to be really, really, really careful if patients present, if they're over the age of 50, 55 years old and they've had mild trauma, I would seriously consider x-raying, okay? If they're under the age of 55 and they've had moderate to severe trauma, then x-ray as well. You know, like a guy fell through the roof of his garage and hurt his shoulder, you know, that sort of thing, that would, and he was like 35, let's x-ray it. We've had cases where FCPs have picked up fractures, even in mild trauma, but in older people. So it's worth just being really careful and be really, really cautious with patients that come in with lower thoracic pain, especially osteoporotic patients. And you may not even know they're osteoporotic, but if they're older and they're coming in with pain around the bra strap or lower, T10, T11, T12, L1, L2 area, always be cautious and consider an x-ray if it doesn't look right, or if they're of an older age group, they may have previous history of steroid use, asthmatics, prednisolone. They may be postmenopausal, etc., and the hormones may have weakened the bones. They may just be older. They may have poor nutrition. They may have had a history of anorexia or bulimia or eating disorders, so the bones don't have the integrity. And it may just take a mild trauma or sometimes no trauma to cause a compression fracture in the lower thoracic spine, upper lumbar spine.
And going on that, I'd say I agree there, Tim. I've picked up on a couple of them, even where the GP hasn't necessarily x-rayed and there has been a mild, like pretty inconspicuous, if you like, event, but they've had back pain for 2 to 3 months. It's correlated with that event. I've gone on, okay, we better just get an x-ray and compression fracture, T11, T12. So yeah, I definitely agree.
Yeah,
there.
thoracic fragility fractures. There's one more that that is very often missed. Actually, it's the ankle. Although it happens after traumas, I've seen that they go to the A&E and they X-ray the ankle, but they don't X-ray the shaft of the fibula. So I've in sort of the last 6 months, I picked up 2 of them, fibula fractures, post trauma though.
Christ, wow.
And were you doing auto ankle rules, Alan, or
Yeah.
higher up fibula?
So yeah, on examination, you're just going to look for that really acute tenderness,
Yeah.
palpation on the fibula.
Also weight bearing. They kind of struggle to.
I think your connection's a bit poor there, Alan. So one thing that I've started doing in terms of x-rays and investigations is I keep it's based on something I had a conversation with Will about before, is keeping a record of all the patients I send scans for, and then keeping a note of the findings that come back, and just do that self audit of what's your sort of hit rate of finding significant things. So when you see something, you pick it up, you send them for a scan, and it comes back with, you know, positive ACL rupture, it just helps confirm in your mind, okay, yes, I was right there. Or if it picks up a meniscus thing, but it's, it doesn't change symptoms, or sorry, change management, and just having that self-reflection of going, I'm sending this many scans, how many of them are coming back with minimal, insignificant findings in terms of your management? Yeah, I just thought I'd mention that as a way of just auditing yourself. The other thing as well is on the stat sheet, there's obviously that document there of how many times we're referring patients for x-rays, MRIs, and blood tests. And Will and I spoke briefly about this this afternoon in terms of if that percentage starts creeping up. My view is the percentage doesn't mean anything really if you're justifying all the scans that you're sending for. So if your percentage is 20% and you're picking up hundreds of fractures, yeah, great, perfect application of clinical reasoning and so on. But if that percentage is 20% and, you know, things are coming back, who's the guy in Wandsworth whose report is always, what's his name?
Alan Grundy.
Alan Grundy.
Oh,
My
no
mate,
abnormality
Alan.
detected.
What's his catchphrase? No
bony abnormality.
No bony abnormality. That's it.
Mate, do you reckon he looks at the scan or he just sign it?
Just no bony abnormality. That's all you get from it.
Copy and paste and copy and paste.
Yeah, just again and again and again. So if we're sending scans off and it's coming back with an Alan Grundy, we need to be self-reflecting on that and going, if your clinical reasoning is there, if you've done your Ottawa rules and you've gone, there's tendinous on palpation, they can't weight bear 4 steps, I think it is, and you send them off and it comes back negative. If you've followed those guidelines, that's perfect reasoning. But if we're just sending scans and it's coming back, Alan Grundy,
maybe refer on to someone else for another opinion, eh?
Maybe we shouldn't call it that. Yeah, I'm just conscious now it's going to be like a catchphrase and then it's going to come back at me in like 5 years' time or something. But I think self-reflection, if you're noticing that your referrals there are creeping up and you've got 12-15%, it might be time to just start reflecting on that and going, am I over referring because of Uncle Ben from Spider-Man going, with great power comes great responsibility? And if we get audited or someone comes and checks and GPs ask, my understanding is that all the scans are paid for out of the local GP, what are they called? PCNs. And they might come back and say at the end of the financial year that they've paid out, this much money in terms of scans, and where all the scans come from. If you can clinically justify why you sent for scans, my view is that's perfectly fine. I think Tim's view would be the same on that. But if there's poor clinical reasoning there, I think we need to do some self-reflection and just figure out where we can improve.
Also on that note, Chris, can I add? I mean, I've seen in certain practices where I'm sitting, I have dual FCPs. They don't usually follow up. It's important to be follow up on those cases as well, because when the scan comes back, it goes to the GP, and the GP has no idea what to do about it. I mean, of course, if it's a fracture and stuff like that, they would take care of that. But it is our responsibility. Sort of in the future, it shouldn't come back and bite us that we request for a scan and never looked at it.
Yeah, yeah, that was something that was happening with me. Is I was sending for scans, and then I never heard back because I work in a hub setup, so 6 different clinics, and I'd have to log in to order them and check them all up and so on. And scans were coming back, and it was like, an ACL, or this was happening and this and that, and I just wasn't hearing about it because doctors were seeing the report and then just
Filing it away.
yeah, just sending them on or managing it. And when I went back and looked at it, I was like, oh, he actually did have a tibial plateau fracture, or he did have this or that thing. And it was really good for me to go, hey, I am actually picking up some cool things, and it's cool for me, not for the patient, but it just helps you think, okay, we get moaned at a lot and patients complain of this. One patient I phoned last week, I was 14 minutes late for his appointment, and he had a good old blast at me for being 14 minutes late. And I was like, mate, you have no idea. But we get moaned a lot, and I think it's good to just have that, like, thumbs up, you did something good, in the 14 patients you saw that day, you at least got something right. So I think following up on them, like you're saying, Alan, is really good, because if we're referring them, it's the it often says there, it's the referring clinician's responsibility to manage this patient. Because it's also something I've noticed is sometimes it'll pick up like a fracture, like a stress fracture or tibial plateau fracture, but they won't necessarily action that themselves and say, hey, go to emergency. They just send the report back, which I just find interesting. They won't go, right, just walk around the corner and go to A&E and get this fixed. But system things, I suppose. Last thing I was going to do, and I'm conscious of time, is a good thing I picked up from Therapy Live as well, is practicing how we give feedback or how we explain things to patients. And one of the guys that did the talks, he recorded himself explaining to a patient why they've got sciatica, and then hearing it back. And sometimes I think if you hear yourself back explaining something like a meniscus teres or a sciatica, you might actually go like, I don't even make sense to myself sometimes, in terms of you're jumping around and you get confused. So I thought, in terms of I thought I'd just put Will on the spot and get him to explain this finding. Hold on. So no, oh, now it's share screen. There it is. So patient came in with a knee, and can you see that, Will?
Yeah, I can see it.
So patient came in, she's 63, she's got a lot of knee pain. She used to do a lot of walk around Wandsworth Common 10 times. Now she can't even walk to the Common and back. She's got a lot of knee pain, hobbling around. She's tried shoes and walking sticks and weight loss, but it's been locked down. She's put on more weight and so on. She had this x-ray done. How would you explain that to a patient? Well, no pressure.
Thanks, Chris. So I would explain that. So I'm just reading it fully. Fine. So I would probably explain to them that in terms of the X-ray, there has been some degenerative changes found. So some arthritis. I always don't like the use of the word wear and tear sometimes, because I think it almost desensitizes the pathology that the patient has got. I don't think we need to be scared of using the word arthritis. So I'd be explaining that in the medial compartment there was some mild arthritis suspected. Then I'd also be explaining that within the lateral compartment, so the outside of the knee, I think you need to use patient terms here, that again, it did find some arthritis. As to the level, obviously the report hasn't been particularly specific on that. Degenerative changes most notable. Obviously they've said mild on the other side, so from our point of view, we could probably assume that's mild to moderate, but ideally you'd probably want to know a little bit more, especially as you say, if her symptoms are so severe. So I'd be explaining to the patient, X-ray has come back with some mild arthritis, possibly some moderate arthritis, more marks in the outside of the knee. I always like to say to patients, because I think the things that they always think of are fractures and everything like that. So I'd be explaining there's no fractures, the bones are aligned, but it is the arthritis that we need to work on. As you say, Chris, going by her symptoms, it's whether we potentially need to investigate this a little bit further, considering her level of debilitation. Because again, it's about that clinical correlation. Potentially her symptoms are far more severe than we're looking at this X-ray here. So yeah. I'd be explaining that to the patient, but also saying that just because the report has come back as mild doesn't mean we're downplaying your symptoms by any amount, and then have a really kind of clear discussion with her about the possible options moving forwards. It's debatable whether a consultant would look at this and do a replacement, but I think potentially you'd maybe trial joint injection therapy if conservative management and physio has already failed.
Yeah. Yeah. So just with this patient, she's got quite a marked valgus, trying to show valgus, not deformity, but kind of alignment in her knees. And that's why I kind of suspected that there'd be a lateral joint compartment problem there. And she's been trying conservative management now for at least 3 months, and she's just not improving. Yeah, we can talk about management another time, but yeah.
I think it's quite a poor X-ray report, to be honest. As I say, to go from saying mild to the other side to not being definitive on the lateral side, especially as you say, Chris, with that history of the valgus deformity, we really need to know more about, because obviously the issue is in primary care we can't see the scan. We can't see whether that is moderate, severe. So yeah, I think we just need to maybe find out what the go even contact the radiographer or get a second opinion on that scan result.
Yeah. Well, I think.
Sorry, Chris, can I just ask you something, if you don't mind? You said you saw this patient. Yeah. Is it a varus deformity or a valgus deformity? Did you say she's more marked in the varus deformity? The
legs going outwards.
Yeah. So that would be varus, isn't it? It's the varus deformity. The valgus is knock knees, and the varus is bow knees.
So
you mean valgus, though, no?
Yeah, knock knees. Yeah, so valgus.
Valgus.
Valgus meaning the lateral compartment would be smaller, less joint space.
Yeah.
Yeah.
Yeah. Yeah.
Do you ever use in your explanation? Do you ever go down the path of age-related changes? Do you ever say that in terms of?
Yeah.
Yeah, I think as much as I say it's I'm not afraid to use the word arthritis. I think it's also explaining to them that how old did you say she was, Chris? This lady?
63, I think she was.
Yeah, so that obviously there's let's say it was just a normal knee, no valgus deformity, and we X-rayed that, and it came back as mild lateral joints arthritis, bit of mild medial joint arthritis. Essentially, I tend to say it's the same as some of your hair's going grey. Because as much as you want to be honest with the patient and let them know their pathology, you also don't want to scare them, because I think arthritis has a bit of a negative energy in the physio world and in the medical world. It doesn't need to be a negative word, but I think the way people think of it, they think, okay, that's bone on bone, I need a knee replacement as well. So yeah, I use it quite a bit, Dan, or kind of go around it in a similar way.
Yeah, what I often do is when I'm like almost reading the report back to them, I'll use the medical words and so on, because I think it's it's a responsible thing to do. But then when you're explaining it more, is then use the analogies of age-related changes or grey hair. I'm 34 and I'm already half grey, so I can say, look, it starts already. Age changes happen and so on. So I think my view is to still give the medical words and not call it, something crazy. Crumbling discs and things like that. Just don't think that's helpful in any circumstance. But
so if you had a lady with lumbar spine with degenerative disc degeneration, do you tell them that, or you just say age-related changes?
Yeah.
I tell them.
You tell them
that the disc is degenerative, but then I'll explain as to what that means, that it can be considered relatively normal. I often refer to a study, much like the ones you showed earlier, Chris, and said, look, these are the percentages on asymptomatic people that find this pathology. It doesn't necessarily mean it's going to be a big issue.
I suppose it's about picking your patients as well, isn't it? If you've got
definitely
pretty kinesiophobic and you know that there is some maybe psychosocial factors, and you're going to be a little bit more cautious.
I think the reason why I hesitate with back pain is I think there's something slightly more, the psychosocial factors and fear avoidance and things like that are probably more prevalent in lower back pain, and more fear avoidance of avoiding movement and so on. If you say disc,
don't say disc. Don't dare say disc.
Disc degenerative disease, especially disease, I think is quite a strong phrase.
My L8 disc.
Yeah.
I'd say
I can feel it. My disc has moved. Okay.
Yeah, I'd say in this chronic cases it would be like it's like a catastrophizing event going on in their head when you tell them something like that. So fear avoidance and stuff like that. Yellow flags is something to look out for, and be careful on those terminologies really with the patient, I would say.
Yeah. Cool, guys. We've gone a few minutes over, so we don't have to go much more unless anyone has anything particularly burning to say.
I've got a quick question for Tim. In terms of you're in a practice and a GP keeps sending you patients with all the scans under the sun, and you're not really appreciating that because it is building a bit of these patients are coming to you with an expectation or an understanding that they're broken, fragile based on these scans. Are you having a conversation with the GP?
No, I never do anything to create any kind of conflict or not saying that it would create conflict, but any kind of polite education of the GP on how they should be more appropriate with their imaging requests. I would just deal with it and just say, yeah, that's fine. That information adds a bit more to the clinical case, and so look, if that's what the GP's done, that's fine.
Just keep looking at that GP during the in-service when you're giving it about imaging.
Yeah, I mean, maybe we could offer a in-service training for them, and then you can do it generally rather than because what we see, we actually saw this a little bit with the Georges guys, didn't we? At Bridge Lane, they were being a little bit critical of the way the GPs were handling some of the referrals, and so yeah, and we were keeping well out of it. When the patients were going direct from the reception team or whether they're going direct from the GPs to the FCP, and they got a bit of a telling off, they never, so.
All right, noted.
We had a little bit of that in Northeast London as well. The MSK lead sent back the referrals saying that they need to go through the FCP first and then come in through the MSK referral because they've not done any self-management. So we had a little bit of the MSK team kind of telling off the
GPs,
yeah.
They don't usually take it too well, but
they didn't take it really well, but yeah.
Actually, to be honest, on the other side, Patchmore surgery, the GPs were like, probably you can do some in-service training and tell us more about when to request for investigation for MSK cases. I was like, oh, that's great, thanks. Probably someday.
Good.
Great to see everyone. Thanks so much
Yeah.
for turning up, everyone. What a turnout today. Brilliant. Thanks for your brilliant expertise and thanks for setting it up, Chris. So good to see you all. And I will share this with the team. Welcome to new members. Thanks for joining in tonight. And we'll look forward to seeing you. When's the next one, Chris? And have we got anyone that wants to present the next one?
There was a recommendation. Dan, did you have something?
So Alice didn't Alice have a
Oh, yeah.
from Chelsea and Westminster?
That's a good call. Yeah, Alice has got a
We'll have to
Alice,
chase that up because I think that's gone a bit quiet. But
yeah, let's double check that. So Alice is in touch with an orthopedic surgeon at Chelsea.
that
and
could be
Westminster,
next
quite
week,
keen
but
to
we'll have to
do
double
next
check
week.
with Alice.
Yeah, I think next week as early as possible. I think he wants to do 7:15 or 7, possibly 7:15 or 7. Yeah, 7:15 or 7. But we'll let you know.
All right, see you guys.
Thanks. Had a great work, guys. Good to see you.
Thanks a lot, guys.
Thank
Take
you.
care.
Thank you.
Thank you.
Bye.
Bye.